Sure.
Okay, can we begin? Hello?
Jitesh, you can even give 2 minutes introduction, or should I give?
அதுதான் மேம் கவிதா ஜாயின் பண்றேன்னு
I
சொன்னாங்க
do
மேம்
not know
இதுக்கு.
if the same number of students join பண்றாங்களான்னு தெரியல. Very brief introduction about NMO for 2 minutes, and then NMO mantra, and then you can start the session. 3 minutes, okay?
எஸ் மேம்.
Total. சரி. Right, speak something. Speak something now, ma'am. Hello. Jitesh, say something. Hello.
Hello, yes, ma'am. Hello, am I audible, ma'am? Hello? Hello? Hello?
Namaste. We'll start today's sessions with the NMO mantra. Natvaham kamaye rajyam, na swargam na punarbhavam, kamaye dukkha taptanam, praninam artinashanam.
Hello? Hello? Kavita, speak something.
Ma'am. Ma'am.
சொன்னா கேக்குது.
Ah.
நான் ஹெட்ஃபோன் போட்டேன். கனெக்டட்
இப்பதான்
ஃபார்
ma'am
எல்லாம் வருது, ஆனா ஹெட்ஃபோன்ல கேட்கல. Can you introduce NMO and also chant Om thrice and NMO mantra?
ma'am இப்பதான் மேம் சொன்ன சாண்ட் பண்ண கேட்கலையா?
சொல்லி முடிச்சிட்டியா?
சொல்லி முடிச்சிட்டேன்.
இப்பதான் கேக்குது, அது சொன்னது கேட்கல எனக்கு. 4-5 மேம் கேன் ஸ்டார்ட் ஐ திங்க். Ritesh,
Yes, ma'am.
அது ரெக்கார்ட் பண்ண வருதா?
Ma'am,
Session is being recorded about the
live
live
stream
stream.
பண்ண முடியல மேம்.
Huh?
Live stream பண்ண முடியல மேம். YouTube account verify ஆகல மேம்.
Okay. Okay. So we also will record and post.
Yes, ma'am. I will try
சரி,
after
okay.
4:30.
Okay. Nivethana, by 4 o'clock there were 60 subscribers. I checked.
Yes, ma'am.
சரி. Read. பார்த்துட்டே எப்போ வருதோ then you can start.
Yes, ma'am.
இப்போ 78 participants தான் இருக்காங்க, so we can start. Yes, ma'am. Please start.
Ma'am has left ma'am. Rejoin பண்றேன்னு சொல்லிருக்காங்க ma'am.
Okay. So you are keeping the others in hold,
Yes, ma'am.
Other people in wait line?
19 இருக்காங்க ma'am. Wait line.
Okay.
Hello.
Yes, ma'am. I can see the screen.
Can I start, ma'am?
Yes, ma'am. Please, ma'am.
Yes, ma'am. So I think I am Dr. Nivethitha. Good evening, everyone. First of all, I work as professor in Srinivasan Medical College, Samayapuram. So today we'll be dealing with GIT, RS, autocoids, and endocrine in pharmacology. Before beginning, I would like to tell you some general instructions regarding pharmacology. the common like mistakes which students make while preparing for their exams. First is giving too much of importance to your classification. That is because whenever you see your exam paper, when you see the distribution of marks in any essay question, the classification it carries to a maximum only of 5 marks, but the total essay question is about 15 marks. So when you concentrate only on the classification, no matter how exact you are in reproducing your classification, the maximum mark which is going to be given to you is about only 4 or sometimes for very rare cases 4.5. But if you're not concentrating on the mechanism of action, use the adverse effect of a drug when you're reading it, you are losing the remaining 10 marks. And the other common mistake what they do is concentrating only on the essay questions. While writing as well as while preparing. When you write, total duration of the exam is about 3 hours. The maximum time you can allot for one essay question is 20 or 30 minutes. So by the time it is 40 minutes to 1 hour, you should have done the essay questions and should have moved forward to your short notes because bulk of your marks is in the short notes. Essays just for 30 marks, the remaining 50 is in your short notes. I think some universities have MCQs for remaining 20 marks, some universities don't have, but anyways, your short notes carry the bulk of your marks. So, better to allot time for short notes more than when you are writing the essays. And third is use pictures as much as possible, flow charts or diagrams. Need not be the exact reproduction from a book. You can use your own imagination and do. But see that provided it is correct, that is what is important. I'm not asking you to reproduce exactly what is given in KD Tripathi or Katsang or something. But when you write sentences to sentences, it is better when you represent the same mechanism of action by a diagram so that when the examiners correct your answer sheet, it will be easier for them to mark you because they will not have time to read through the lines one by one because the bulk of papers which are given to them on a single day is very huge. So better to use pictures wherever possible and to highlight the important points and please draw lines after you complete each questions and please go in the order of the question paper. Don't try to write the second short note first, then the fifth short note, then the 10th short note. It becomes very difficult for the examiners when they correct your papers. They might even get frustrated in the process. So as far as possible, stick on to the order of the question paper. These might sound very basic instructions, which you already know. I am fully aware that you know all this. But these are the common mistakes which you make in the exam, which can have a serious impact on your results. So with this, we will go to hormones. Coming to hormones, we have the two main important essay questions in hormones will be uh, from thyroid or from insulin. So first we will finish with insulin, then we'll move to thyroid drugs. I hope everybody is following KD Tripathi. At this place, I would also like to mention that if any of you are following Tara Shenbag, there are a lot of errors in that book. So please verify with Tripathi, have Tripathi side by side. See, especially for the essay questions, there are a lot of actual errors in Tara Shilpa. I have gone through the book. See that whether same is given in Tripathi as well as in Tara Shilpa because the NMC recommends only KD Tripathi as the reference book for UG, not Tara Shilpa. So please counter verify with both the books and write the exact answer. So we'll see about insulin. See, whenever you talk about any drug, the subheading should be mechanism of action, uses and adverse effects at your level. If suppose if the same topic is asked in the PG level, they might ask drug interactions and contraindications and use in special population like pregnancy or lactation. But your level, at least you are expected to know mechanism of action, uses and adverse effects. Do not put too much of stress into the doses. Even if you don't remember the doses, it's fine. But the route of administration is very important. Whether it is a tablet or an injection which you are going to use, that is very important. And the duration of treatment is very, very important. No problem if you are not able to remember the doses. Don't stress too much on that and leave the important things. So when you come to diabetes, the two main important essay questions will be insulin and oral hypoglycemic drugs. When you come to insulin, they will ask you first is classify insulin analogs. That is how the question will begin. So you are expected to write this tabular column: rapid acting, intermediate acting, and long acting, because the use as well as the route of administration will differ. You can use only regular insulin IV, rest you can give only subcutaneous. So you have to write this tabular column basically. Don't worry about the onset, peak, and duration. That is okay. But at least you should know which are the rapid, which are the short acting, and which are the long acting. And when you come to the mechanism of action of insulin, they will ask you, like, just a second. So, when you come to hormones, half of it is physiology. They're not going to ask you the action on carbohydrate metabolism, action on protein metabolism, or action on lipid metabolism. That is not going to be their question, because that is already dealt with in physiology. Whether it is thyroid or corticosteroid or insulin, they are going to ask you the mechanism of action at the subcellular level. So, you are expected to draw this figure. You must have read this in your first year, first chapter, general pharmacology, where you have four kind of receptors. All your drugs are going to act via these four kind of receptors. So you are going to tell first which type of receptor is going to act. When I will, we will see this in growth hormone. We will see this in thyroid hormone. We will see this in insulin. So I'm taking the mechanism of action as a single course now, once and for all. So they are all acting via tyrosine kinase receptor. You are expected to draw this figure. I think you know this. You have an intra as well as an extracellular domain. Then, when the unliganded state, they are existing as monomers, and the ligand binds, there is dimerization. And then you have in the intracellular domain, you have intrinsic tyrosine kinase activity, and the tyrosine kinase phosphorylases downstream kinases. And which mostly these drugs are, these tyrosine kinase receptors, drugs which act through tyrosine kinase receptors, are mostly involved in cell proliferation. So they will be mostly activating mitogen activated protein kinases and downstream kinases. So you are expected to draw this figure, whether it is a growth hormone, whether it is a thyroid hormone, whether it is a insulin. When we talk about corticosteroids, androgen, estrogen, they are also going to act via the same type of receptors. They are called as steroid receptors, that we will deal when we are talking about corticosteroids. So that is one important thing. And the next what you have to do is you have to draw this figure, because the requirement of insulin they will ask you. So it is 0.4 to 0.8 units. In some people who are obese, it can go up to 1.6 units. And then you have to talk about this regimen, because short acting as well as long acting insulins are used. So this regimen is with short acting insulin, and you have to write the time of administration of insulin, which is ideally 20 minutes before food, because insulin is available as a hexamer. So for hexamer, for it to dissociate and it to become monomer and then to reach the site of action, it will take about nearly 20 minutes. Mostly what students make mistake here is with food or after food. With food, what happens is it will lead to early postprandial hyperglycemia and late postprandial hypoglycemia. So this you are expected to write. So when you come to this regimen, this is a short acting, either it is Lispro, Aspart, or any short acting analog with the long acting insulin. That is, they are called as peakless insulin. So they can act round the clock, glargine or detinib. Or this regimen is with regular insulin, and with you are mixing this with Lispro. You have this NPH, neutral protamine HCOG, which is intermediate acting. That 70% with the short acting. So that mixture is called as 70 to 30% mixture. So you have to explain about these two regimens whenever insulins are. So we are done with the mechanism action. We are done with the uses. Adverse effects, I think you will know. You can divide them into local and systemic. Local, mainly the adverse effects in insulin. We have to talk about lipodystrophy, because there is hypertrophy of the site where you inject, and the atrophy is the rest where. So you have to, what you have to say is, have to practice rotation of sites. That is, you should not inject insulin in the same site. Suppose you are choosing best is absorption is best in the anterior abdominal wall. Suppose we are choosing any other site, so you can choose anti-abdominal wall, then you can go for anterolateral side, then you can go for deltoid. So you have to tell that. So, and hypoglycemia is the main common adverse effect when you use with insulin. So you can divide the adverse effects into local and systemic. So we have explained about, and mainly insulin is the drug of choice where in type 1 diabetes and in gestational diabetes mellitus, whenever patient is having gestational diabetes, or diabetic patient becoming pregnant, even if she is on oral hypoglycemic drugs. Although we get evidences that metformin is safe in pregnancy, the guidelines still now suggest that you have to stop hypoglycemic drugs and you have to switch over to insulin. So we have to explain all this. And adverse effects, I think we have dealt with already. And the next thing they can ask in short notes is diabetic ketosis, where you have to explain this flowchart, because you will know only this flowchart will say why there is dehydration, why there is acidosis, because of excess of glucose, all these things happen, and why there is ketonuria. Then the management, in the management of DKA, the main thing you have to stress is which type of insulin. It is regular insulin IV, and this dose up to when the glucose falls to 300 milligram. This is very, very important. And intravenous fluid, which intravenous fluid you will use? Normal saline. Potassium, it's correct itself when you give insulin. If it is not corrected, you can add potassium. And similarly, acidosis corrects itself when you correct the dehydration. But still, if you find the pH is like 7, you can give bicarbonates. So phosphate is also same. So when you find the phosphate to be low, you can correct it. So these are as far as insulin is concerned, these are two things they will ask. Classify insulin analogs, mechanism of action, use and adverse effects of insulin. Question can be like this: add a note on diabetic ketoacidosis. So that will be the essay question when it comes to insulin. Insulin resistance is not like it's not up to your level. Then when you come to oral hypoglycemic drugs, you have drugs acting on incretin axis and you have other drugs. So when you talk about drugs acting on incretin axis, you are expected to draw this figure. So I think it is okay. So you have this incretin. What is incretin? You have to explain about that. When you take glucose orally and when you take glucose IV, there is a difference in insulin release. When you take glucose orally, there was more insulin release. So why this happened? Because your gut releases a hormone called as incretin. So you have GLP-1, GIP, all these are incretins. So in this, the main 4 actions of GLP will be 1, 2, 3, 4. It stimulates insulin release, inhibits glucagon release, increases satiety, so decreases appetite, and it also decreases gastric emptying. So this will be the mechanism of action for exenatide, liraglutide, pramlintide, everything. And even for DPP-4 inhibitors like vildagliptin, sitagliptin, and saxagliptin, because this GLP-1 is degraded by DPP-4, and when you inhibit that enzyme, the action of GLP-1 is prolonged. So it is indirectly mechanism of action is the same. So you have to write, you have to draw this figure, whichever drugs acting on the incretin axis is asked. So that is what they have explained here. And when coming to the adverse effects, they are not causing hypoglycemia. These drugs cause some weight loss. So they are used off-label for obesity. If you want, you can highlight that point. And exenatide causes pancreatitis. That is very one important side effect. And then pramlintide can cause hypoglycemia. When you come to drug interactions, I will tell you interactions can occur at 4 steps. You must have read in pharmacokinetics: absorption, distribution, metabolism, and excretion. Absorption, you can blindly write for any drug. There are drugs which will interfere with the absorption. Say, for example, antacids. Antacids will definitely alter the pH and interfere with absorption. Anticholinergics will delay the gastric emptying, interfere with absorption. Then you have tetracyclines. Then you have, there are certain drugs which you can use commonly in drug interactions. And similarly, when you come to metabolism, you must have read about enzyme inducers and enzyme inhibitors. Enzyme inducers, most common is rifampicin and your anticonvulsants like phenytoin and carbamazepine. So, which especially if you find that a drug is metabolized by CYP3A4, you can write these drugs anywhere. Definitely, they are going to interact because these are the drugs which are enzyme inducers. And enzyme inhibitors, you have your azole antifungals like ketoconazole, and you have your macrolide antibiotics like erythromycin and clarithromycin. Azithromycin does not inhibit CYP3A4. So, whenever you ask, whenever you drug interactions, if they are asking the question, and if you don't remember it, this you can write commonly for any drug because most of your drugs are metabolized by CYP3A4. So you can confidently write these drugs: enzyme inducers, enzyme inhibitors, absorption. Some drugs will compete with plasma protein binding. If you remember that, you can write. Otherwise, up for your level, mostly that is not expected. Maybe if it is a PG question, they are expected to write. Then coming to oral hypoglycemic drugs, I think whenever you write classification, better to present it this way like a flowchart rather than writing it like one by one. When you have one group, then you write the other group. And one more thing I would like to say is, especially when it comes to cephalosporins classification, you have lot of drugs like first generation, second generation, third generation. If you are not able to remember all the drugs, it is okay. When you write the heading and you write the subheading, you write 2 or 3 drugs in each generation, it is fine. But when that same drug is asked in a short note, say for example, ceftriaxone, you should know that this comes under third generation cephalosporins. Only then you can write, you can elaborate on ceftriaxone. So that is the difference. When you write in the classification, if you're not able to remember all the 10 to 12 drugs, it is okay. First 3 or 4, or prototype drug, if you highlight and write, that is fine. But when you come to the short answer, say for example, ipratropium. If you are not able to remember the ipratropium is an anticholinergic, you will not able to write the mechanism of action used in adverse way, because in pharmacology, there is a drug which is designated as prototype. If you read your KT Tripathi, when that drug is designated as prototype and the mechanism of action used, the adverse effects are going to be the same for all the drugs coming under the same classification. So if you read once for the prototype drug, everything is going to be the same. But for that, you should know that this drug comes in this group. That is the main problem. So for that, you can read the classification. So coming to sulfonylureas, if you read this tabular column, these are all the if you read this tabular column, you have all the salient points here. So tolbutamide is short-acting, libenecamide is a single daily dose. This is safe in elderly. This is safe in renal failure. Glycoside has antiplatelet action. So all these things, if you highlight, that is more than enough. And similarly, meglitine, rapidly attack, they are used for postprandial hypoglycemia. Gliptins we have discussed already. Metformin, the advantages is doesn't cause hypoglycemia. But side effects, we'll see that when we talk about metformin, pioglitazone individually. So when you go to sulfonylureas, the mechanism of action, I think you have a figure both for sulfonylureas and meglitinin analogs. If you draw this diagram, it is more than enough. It is acting as sulfonylurea receptors, blocking sodium channels, so increase in calcium, depolarization, insulin release. So that is the mechanism of action. And in sulfonylureas, you have some adverse effects, hypersensitivity, disulfram-like reaction with alcohol, and you have weight gain, which are not seen with newer sulfonylureas like glipizide and glycosides. And they are drugs with very high plasma protein binding. So when you talk with drug interactions, you can just mention drugs with few high plasma protein binding capability like aspirin, methotrexate, sulfonamides. You can just mention. I have already told you, if you see this list itself, you can see ketoconazole, warfarin. So when you enzyme inducers and inhibitors, you can confidently write. So hypoglycemia, hypersensitive, weight gain, and disulfram-like reaction. Repagline, I told you already, it is mainly for postprandial hypoglycemia. Other side effects are very minimal, so you will draw this figure. And DPP-4 inhibitors, we have discussed the mechanism of action already, the same as that of GLP. When you talk about vildagliptin, sitagliptin, and saxagliptin, the only main thing what you are going to highlight here is which is metabolized by CYP3A4, which is not metabolized by CYP3A4, because when it is metabolized by CYP3A4, you're going to have a lot of drug interactions. If it is not metabolized, it is safer. So you can see in tenagliptin, it is causing QT prolongation, so it can cause cancer at this point. So these are the minor points which you can highlight. When you come to metformin, this word is very, very important, AMP kinase, because that is the mechanism of action of metformin. And suppression of hepatic gluconeogenesis, that word is also very, very important. And uptake of glucose to glucose dependent tissues like liver, muscle, and adipose tissue to GLUT4. That is one important thing. Metformin main adverse effect you'll expect is metformin is fully it's not metabolized, excreted unchanged in the kidney. So any renal failure patient is contraindicated. Dose has to be titrated with GFR. That is very, very important. Common side effect when you talk about metformin is gastritis, but very rare and serious side effect when you talk about is lactic acidosis. That is especially common with patients in all type of failure, liver, renal, cardiac failure, because they all will go for hypoxia, and that hypoxia will precipitate this. And vitamin B12 deficiency. When you talk about advantages, it is does not cause hypoglycemia. It also causes some weight loss. So these are the advantages of metformin. If you want, you can highlight. Similarly, pioglitazone. Here you have to main word you have to mention is PPAR gamma and GLUT4 expression. Differentiation of promoting the differentiation of adipose tissue. That is very, very important. Then favorable effect on lipid profile, raises HDL. So here also you can see drug interactions, and when I talk about pioglitazone, main drug interaction will, the main side effect will be edema. It causes all edema, cardiac failure. So it precipitates edema, osteoporosis, and now you have recent reports of bladder cancer also. Acarbose, important point here you have to tell is it is a drug used for postprandial hypoglycemia, inhibits alpha glucosidase. Main side effects will be because of retention of carbohydrate, you have flatulence, abdominal discomfort, and bloating. And when sometimes now these days what they are doing is they are giving a clinical scenario and they are asking you the outline the manager. So in that case, in whichever chapter you take, at the end there will be a what should I say, algorithm like this. It is asthma or it is hypertension or diabetes. You please have this guideline memorized. Because sometimes for outline the management, a separate mark is allotted. I think 2 marks or 3 marks, something like that is allotted. So please see that you write this, have this guidelines memorized also. So that is the important thing is when you talk about insulin and OHA. Then we'll move to corticosteroids. Corticosteroids, they're not going to ask you synthesis. Definitely, they're not going to ask you actions on carbohydrate and protein metabolism because it is done within biochemistry and physiology. What they might ask you, how does it act as a immunosuppressant? This is very, very important. One thing you can say, it inhibits phospholipase A2. Because of that, arachidonic acid synthesis is stopped, and so you don't have cyclooxygenase, lipoxy, you don't have prostaglandins and leukotrienes, and also it doesn't express the adhesion molecules. So, and it inhibits all the cytokines and cell-mediated immunity, and humoral immunity is also suppressed. So, this thing you can, I have just summarized whatever is given in this tabular column. I told you mechanism of action of steroids and thyroid hormone and even vitamin A and vitamin D is via the same mechanism. So what does it do? These come under nuclear receptor classification. So you have same thing in the unliganded state. It is coupled to heat shock proteins and it is bound. And in the liganded state, what happens is it comes and it translocates into the nucleus. Receptors are actually in the cytoplasm. It translocates into the nucleus. In the DNA, you have specific sequences called responsive elements. If I take for corticosteroids, it's CRE, corticosteroid responsive element. You have TRE, thyroid hormone responsive element. You have estrogen responsive element, testosterone responsive elements, and so on. So it will trigger the transcription of that particular segment in the DNA. And you know what is transcription? From DNA comes RNA, and from RNA comes proteins. So the duration, I mean the onset of action for all these hormones is going to take some time, because for all this to take place is going to take 2 or 3 days, whereas for if you take for an ion channel, it is going to be within fraction of milliseconds. So you cannot expect an immediate response when you start steroids. That is point in from the clinical point of view. Then you have the classification. I think you will write the short acting, intermediate acting, and long acting. In steroids, you have to just make a note of which is pure mineralocorticoid, which is pure glucocorticoid, which has both mineralocorticoid and glucocorticoid activity. That point, if you highlight, that is more than enough. Uses of corticosteroids, you can divide them into as a replacement therapy and for other diseases. So when you have acute adrenal insufficiency, it is always for emergencies, it is hydrocortisone 100 milligram IV 8 hours. So that is status asthmaticus or any emergency where you need immediate replacement of steroids. That is in congenital adrenal hyperplasia, also it is hydrocortisone. Then for you have a range of autoimmune diseases where I can use rheumatoid arthritis, osteoarthritis, rheumatic fever. When you talk about uses, you just write the uses. It is enough. I am not asking you to explain how it is used in rheumatoid arthritis, what is the mechanism it is effective in osteoarthritis. That will be too much beyond our scope. You will not have time to explain also. You can write autoimmune diseases like SLE. Then you have bronchial asthma. We'll talk about it in detail when we deal about bronchial asthma. Then for fetal lung maturity, if you are delivering a preterm fetus, say for example preeclampsia or something, you have to give to the mother betamethasone or declamethasone, not to the child. That is very, very important. Then in eye disease, Crohn's disease, ulcerative colitis, the uses are like extensive. If you just mention them, it is more than enough. For the adverse effects of corticosteroids, I expect all of you to draw a figure like this, because adverse effects are for corticosteroids are from head to foot. You take your brain, depression, psychosis, eye, topical, glaucoma, systemic, cataract. Then you have anxiety, insomnia, decreases the risk of stroke, cataracts, I told you already, acne, ready bruising, Cushingoid habitus. Then you have increased risk of hypertension, cardiovascular disease, increased risk of diabetes, of increased risk of infection because it is an immunosuppressant, increased risk of peptic ulcer, increased susceptibility to fractures because it makes your bone weak, venous thromboembolysis, and fluid retention. So whenever you read any side effect, you can make is this figure. It is not a very difficult diagram to make. You can just draw a person like this. If you remember the side effects from head to foot, you can remember side effects for any drug. Thing is, we have to, when you are studying itself, if you have studied like this, It will be easier. Otherwise, most common answer what we get when I ask any side effect, nausea, vomiting, nausea, vomiting. Not every drug causes nausea, vomiting. We are sick and tired of hearing this in viva. I'm really sorry to say this. Pathetic thing is even for antiemetics, it is nausea, vomiting. When the word itself says it is antiemetic. So if you have some rationale, you can you will be able to memorize the adverse effects, and you will be able to tell us better even because we have studied pharmacology for a long time. So that's it when coming to corticosteroids. In androgens, I think they are going to ask you main question will be drugs used for erectile dysfunction. It's going to be a short note. Anabolic steroids, they are obsolete. They are not asking these days. So we'll go for drugs used in erectile dysfunction. So the drug of choice for erectile dysfunction is first we will start with sildenafil, vardenafil, and tidafil. They can ask you 5-alkylase reductase inhibitors and anti-androgens. Mainly they are used in treatment for prostatic cancer, that is with the advanced stages, stage 3 and 4, because testosterone is converted to dihydrotestosterone by 5-alpha reductase, so which is the active metabolite which is responsible for the growth of the prostate. And they are used in combination with GnRH agonist or antagonist. That is one important thing you have to say. And they address the static component of benign prostatic hypertrophy, not the dynamic component. Dynamic component will be taken care of by alpha. Okay. So whenever you use any, see, tamoxifen, anti-estrogens you have, they are used in breast cancer, and you have anti-androgens. The side effects are not going to be just the deficiency of hormone. Imagine if there is no estrogen in a female's body, what is going to happen? She is going to have changes similar to menopause. Menopause body naturally stops producing estrogen, so she is going to have symptoms of menopause. That's all. Hot flushes, vaginal dryness, osteoporosis. Come to male, gynecomastia, loss of libido, impotence. So if there is no need for you to mug up the side effects, you use some rationale, you can derive the side effects on your own. Anti-androgens, anti-estrogens, they are going to block the action of androgens and estrogens. So whatever is there when estrogen was there in your body, it's not going to be present. That's it, simple as it is. So phosphodiesterase inhibitors, I think they are the first drug of choice for erectile dysfunction. And you have sildenafil, vardenafil, and tadalafil. So this GTP is converted to cyclic GMP by the enzyme phosphodiesterase 5, and that when that is inhibited, there is more prolongation of cyclic GMP, and that causes vasodilation. So you have because of that penile erection. One thing, main thing you have to highlight here is fall in blood pressure, because they can cause vasodilation of other blood vessels. So fall in high blood pressure and hypotension. Main thing is it should not be combined with nitrate. This produces dangerous hypotension. Even you might even lose the patient. If you want to give, you have to allow minimum of 24-hour gap between nitrates and sildenafil. And suppose this PDE5 is present in your penis, so you have other isoforms. Example PDE6, which is present in your eye, so some disturbances in color vision is also possible. Then you have tadalafil and vardenafil. They are longer acting compared to sildenafil, so they are absolutely contraindicated with nitrates. At least sildenafil you can allow a 24-hour gap, and vardenafil also prolongs the QT interval. Then you have pipe therapy, papaverine and phentolamine induced penile erection. So you can write about that. Then coming to, I think next is estrogens. Estrogens also, they are not going to ask you about the action, mechanism of action we have discussed already when you talk about corticosteroids. Same figure if you draw, they're not going to ask you about all the secondary sexual characters, because all this is dealt within physiology. So they are this is very important. They are absorbed orally, and you can they are metabolized by glucuronide conjugation. And main thing here they are going to ask you is oral contraceptives, and tamoxifen and raloxifene they can ask you. Hormone replacement therapy is not for your level. So when you talk about tamoxifen and raloxifene, they are called as SERM. Why are they called as SERM? They are selective estrogen receptor modulators, which means they are going to act as an agonist in certain tissues and an antagonist in certain tissues. How is this possible? When we spoke about steroid hormone receptors, we spoke about translocation to the nucleus and stimulating the growth hormone, stimulating the hormone responsive elements in the DNA. But this is not always the case. Like in HIV life cycle, when you read, I think you must have read about co-stimulatory molecules, CCR5 and CXCR4. Similarly, here you have co-activators and co-repressors. So when it binds to a co-activator, it is going to act as an agonist, and it binds to a co-repressor, it is going to act as an antagonist. That is why it is called as modulator. Modulator means it's not a pure antagonist, or it's not a pure agonist. It's based on tissues. When you take tamoxifen, it is an antagonist in the breast, but agonist in the endometrium, agonist in the bone. So it doesn't cause osteoporosis, but it can cause endometrial carcinoma. It produces symptoms similar to menopause, hot flushes, and vaginal illness. So and it has a favorable effect on lipid profile, like estrogen increases HDL. But when you talk about raloxifene and ormeloxifene, raloxifene is a antagonist in the endometrium as well. So there is no risk of endometrial carcinoma. But raloxifene has a favorable effect on bone profile. So it can be given in postmenopausal women with osteoporosis. But now the drug of choice for osteoporosis is bisphosphonates, which we'll be seeing in the next slide. So these are the things which you have to highlight when you talk about any drug. So, and then you have aromatase inhibitors. Aromatization, uh, it is happening in the postmenopausal women. What happens is, so this is the mechanism of in breast cancer. If you draw this figure, it is more than enough. You have you have selective estrogen receptor down regulator, fulvestrant, which is going to degrade the estrogen receptor, and aromatase inhibitor. See, when you have a postmenopausal woman, we will be thinking that there is no estrogen in her body because her ovaries are atrophied. But there is estrogen still in her body because of process called EAA, extra adrenal or extra glandular aromatization. So when you inhibit this aromatase enzyme using these drugs, anastrozole, letrozole, exanostin, there is no ligand for the estrogen receptor to bind. That is, there is no estrogen for the estrogen receptor to bind. So when you write about aromatase inhibitors, the main point what you have to highlight is they are used for breast cancer in postmenopausal women. But when you talk about tamoxifen, they are used in breast cancer in women of all stages, reproductive age group, premenopausal, postmenopausal. And it is the only drug which is approved so far for prophylaxis of breast cancer in the contralateral breast. This is very, very important when you talk about tamoxifen. But since tamoxifen has some agonist effect as estrogen, especially in endometrium, endometrial carcinoma can be a side effect, and deep vein thrombosis can be a side effect when you use tamoxifen. This is not seen when you use anastrozole or letrozole because they don't, estrogen itself is not produced here. But the favorable effect on lipid profile is also not seen when you use aromatase inhibitors. Then the most important thing which you are going to talk is about oral contraceptive pills. Progestins, I think uh, individual drugs are not asked these days. Mifepristone can be asked in a short note because it is a progesterone antagonist and it is used for mid-trimester abortion along with mifepristone orally 400 milligram along with misoprostol vaginally. So that is the regimen you can give for mid-trimester abortion up to 7 weeks. You can use this. So you can see the given. When I told you I'm not going to repeat the mechanism action used in adverse way because it's same. I'm sorry, mechanism action. It is the same as that of corticosteroid. So there is no use in repeating it over and over again. It is one of the drugs used for emergency contraception. That they can ask you regimens for emergency contraception. You can write about uh, mifepristone and this new drug called uliprostol, which is similar to some SCRM, selective estrogen receptor modulator, have selective progesterone receptor modulator also. So you can write this. Now coming to female contraceptives, you are supposed to write this tabular column. They are mostly combination of estrogens and progesterone, ethinyl estradiol and levonorgestrel. So this is written, and I think you will know this. You have to take in 21 weeks and 21 days in a month, and last 7 days it's iron tablets. So all these things you will write. And when you come to phase fill thing, what you have to say here is dosage of estrogen is kept more or less constant, whereas the dosage of progesterone is changed according to the menstrual cycle. Because in the follicular phase, progesterone dose will be low. As she goes to luteal phase, progesterone will be high. That is what happens in our body. So it is tailored to mimic the normal progesterone levels. So that is one thing which you have to highlight in phase fill. So then we talk about mechanism of action. Mechanism of action for GnRH agonists, antagonists, for estrogens, progesterones, for everything. For OCPs, you can make a figure like this, because this is what happens. From hypothalamus, GnRH is released. Then from pituitary, you have FSH and LH getting released. Then they are acting on estrogen and progesterone. So what happens is, when you give this, when there is excess of estrogen, what happens? There is a negative feedback mechanism. So it inhibits FSH and LH, inhibits GnRH. So ovulation doesn't take place. That is how it acts as a contraceptive. So if you make this figure, it is more than enough. And so you can see the mechanism of action inhibits FSH, LH, anti-ovulatory effect. And even if ovulation has taken place, because there is no progesterone, your cervical mucus will be rendered unfavorable for implantation. It becomes thick. And even if after the ovulation takes place, what happens is your endometrium will be rendered unfavorable for implantation, because deserialization will not take place. Added to that, there is some contraction of fallopian tube, so there is no implantation taking place. So all these things are the effect. The mechanism of action of oral contraceptives. When you come to side effects, you can write nausea, vomiting very safely here. And irregularities in menstruation, obviously they're going to occur, breakthrough bleeding or spotting. But the main serious side effects, what we are worried about here is deep vein thrombosis. So you can just make a figure like this: mood changes, irritability, depression, and deep vein thrombosis, incidence of stroke and myocardial infarction. So they are contraindicated, or they are relatively contraindicated in women above 35 who is obese, who is having a migraine already, who is having peptic ulcer, diabetes, hypertension, because it has unfavorable effect on lipid profile. So it is relatively contraindicated in these people. So you can also have acne, eczema and all that. So when you talk about any side effect, please make a figure like this and memorize. I told you already, can precipitate diabetes. So we have discussed about the complication. Hypertension, liver disease, malignancy can cause breast cancer also. So that's it when you talk about oral contraceptives and estrogen. Then here, oxytocin and uterine contralytic, tocolytics, they are going to ask you only about oxytocin. Oxytocin, I think you will be knowing. Um, when you oxytocin and uterine tocolytics, if you just make this is a uterine muscle figure. So all the drugs you have, it comes here. You see beta adrenergic agonist, G protein inhibits cyclic AMP, so inhibits cyclic AMP inhibits myosin light chain kinase. Then you have prostaglandin receptors. Then you have COX inhibitors, which will inhibit prostaglandins acting on the uterine myometrium. Oxytocin acts via IP3-DAG pathway and releases calcium. So when you give oxytocin, uterine contraction takes place. When you give oxytocin antagonist like atosiban, it is acting as a tocolytic. Similarly, calcium channel blockers, because ultimately all the pathway terminates in the release of calcium from the sarcoplasmic reticulum and muscle contraction. You can use calcium channel blockers as well as magnesium. Tocolytics are used in places where you need to terminate premature labor when the fetus is immature, whereas oxytocin is used in places where you need uterine contractions. And oxytocin, main thing is you cannot give it orally. That thing you have to highlight, because it is degraded and given intranasal spray or an IM or IV. Induction of labor and in uterine inertia, and termination of postpartum hemorrhage. So these are the main three uses you have to give. And before giving oxytocin, you have to ensure that there is no presentation is correct. There is no cephalopelvic disproportion. There is no placenta previa or fetal distress, and the fetal lungs are adequately measured. So side effects mainly because of excessive contractions. There might be uterine rupture, and you can even lose the fetus. And it also has some ADH-like action. So water retention can be the side effect. Then ergot alkaloids. The difference between oxytocin and ergot alkaloids in uterine myometrium is oxytocin produces contraction and relaxation, but ergot alkaloids produce sustained contraction. So there is one main difference, because in overdose you can go for uterine rupture very easily. And ergot alkaloids are contraindicated in people with, because they have alpha agonistic action. So people with hypertension, diabetes, and cardiovascular disease, they are contraindicated. Pregnancy-induced hypertension, you cannot use ergot alkaloids. So ergot alkaloids are mainly used for induction of labor and for control of postpartum hemorrhage. Ergometrine or methyl ergometrine is given IM because when you give IV, directly acts the heart, produces arrhythmias and coronary vascular spasm. So these are things that you have. The tocolytics I have explained already with that figure. All these ducts mechanism action is covered. So with this chapter, I think it is over. Calcium balance, the main thing is they are going to talk about only bisphosphonates. Rest of the drug they are not going to ask you. They can ask you about cinacalcet because it is a newer drug and it is acting via the CASR, calcium sensitizing receptor, which decreases the secretion of parathyroid hormone, which in turn decreases calcium and phosphate absorption. That they can ask. When you come to bisphosphonate, you can draw this figure. This is happening in the bone site of resorption. You have osteoclasts and osteoblasts, and these osteoclasts are attaching to via receptor via ligand called as rankle. There is an antibody for this rankle that is called as denosozumab. They can be asked maybe in 2 marks for those who have 2 marks or in short. So when you talk about cinacalcet, we have discussed already. When you talk about bisphosphonates, you have etidronate, palmitonate, and alendronate. Main thing with etidronate is it is causing gastritis, so you have to ask the patient to take it in the upright position. That is very important. Other than palmitonate, alendronate, and zoledronate do not cause gastritis. Etidronate is given orally. Rest, I think it is given IV or IM. Zoledronate is the longest acting. So I think when you as you read through, these are the points which you just have to highlight. That's all. Mechanism action, you can write this newer bisphosphonates. They also inhibit prenylation of GTP protein involved in cytocancer organization, membrane roughing, and vesicle. Apart from osteoporosis, they can also be used in hypercalcemia of malignancy, Paget's disease, and cancer with osteolytic metastasis. So this you can write. That's all about bisphosphonates and denosozumab. And I think we have to discuss about thyroid before moving to the next chapter. Just give me a second. Any doubts so far? You can just put it in your WhatsApp group. I'll try to answer it later. So when you talk about thyroid drugs, mainly they are not going to ask about thyroxine again here, but they are going to ask you about anti-thyroid drugs. So you have to write the classification of anti-thyroid drugs and management of thyroid toxicosis can be asked in your essay question. Thyroxine is not an essay question as such. So So when you talk about anti-thyroid drugs, again, even though this is a figure which is exhibiting the synthesis of thyroid hormone, when you talk about anti-thyroid drugs, they are acting at these steps. Say, for example, you have salts of iodine. So they are acting at this step. They are inhibiting this transporter. And again, when you go to your propyl thiouracil and methimazole carbimazole, they are inhibiting this enzyme, thyroid peroxidase. When you have iodide salts, what are they going to do? They are doing something called as Wolff's takeoff effect. Excess iodine inhibits the release of hormones for the thyroid gland. So when you draw this figure, and these antithyroid drugs are acting at each step in thyroid hormone synthesis. So when the antithyroid drug question is asked, what I would expect as an examiner is for you to draw this figure and explain at which step it acts as an antithyroid drug. So when you talk about propyl thiouracil and when you talk about pharmacokinetics, this tabular column is more than enough. So you can say what about propyl thiouracil, methimazole, carbimazole. This is which is long acting, which is short acting, which is highly bound to plasma protein bound, which is transferred across placenta, so which is safe in pregnancy, which is contraindicated in pregnancy, which has additional inhibition of conversion of T3/4 to 3. One thing is main adverse effect here is when you talk about proprietary methimazole carbimazole, you can say about liver toxicity, but very rare serious side effect with the methimazole carbimazole is agranulocytosis. So whenever patient comes with sore throat, fever, yeah, you have to stop the drug and go for a complete hemogram. These drugs produce reversible hypothyroidism in Graves' disease. So that is one advantage, and there is no surgical disc or scar, and it is a reversible hypothyroidism. But it takes longer duration of treatment. You need to give them for 1 to 2 years. But when you do a surgery or radioactive iodine, it is immediate. And but there the disadvantage is irreversible hypothyroidism. You have to start the patient on thyroxine supplementation. That is one thing. And radioactive iodine, when it is also contraindicated in pregnancy. So when you before starting radioactive iodine, it is mandated to a beta HCG test so that you rule out pregnancy. So that is the when you talk about advantages and disadvantages, you can discuss this Graves' disease. And sometimes, very rarely, to shrink the size of the gland before surgery, preoperatively, they can be used. Graves' disease and multinodular goiter are the primary indications. Iodides and iodides, we have already discussed what is Wolff-Chaikoff effect. Again, I'm repeating it. Whenever this iodides and iodides asked, you are expected to use that term. Excess of iodides inhibits the own release of hormones from the gland. This is called Wolff-Chaikoff effect. If you write Wolff-Chaikoff effect, they will understand that you have read the mechanism of action. Here also it is used for preoperative preparation. And in thyroid storm also you have some. And radioactive iodine, you should mention about the 121 and 130, 131 and 123. 123 emits beta rays, 131 emits gamma rays. So what happens is there is necrosis, pycnosis, and destruction of the thyroid gland. So these are things you have to do. And for diagnostic dose, you can say 2500 microcurie. Therapeutic is 3 to 6 millicurie. Here the main advantages, there is no surgical risk or scar, but problem is irreversible hypothyroidism and contraindicated in pregnancy, contraindicated in young patients because there is a risk of second malignancy when your neck is exposed to radiation. Sometimes there is a risk of second malignancy like Hodgkin's lymphoma and so on. So they are not suitable for pregnancy and young patients. Then treatment of thyroid storm, definitely it is going to be asked in your viva or in short notes. So you can say propylthiouracil and iodides and beta blockers to counteract the sympathetic overactivity like tachycardia, tremor, palpitation. If beta blockers are contraindicated, say for example bronchial asthma, you can go for calcium channel blockers. And hydrocortisone 100 milligram IV has to be given because any concomitant adrenal insufficiency has to be corrected first before starting it. So then you have to do anxiolytics, cooling because there will be hyperthermia. So this is in thyroid. Then first chapter anterior pituitary hormones, there's not going to be any essay question. I can be very sure about that. But there are a lot of short notes in that. So somatostatin analogs, octreotide, lanreotide can be asked as a short note. When you talk about somatostatin, you're expected to draw a figure which is given diabetes. That is, you have somatostatin inhibiting both insulin and glucagon. You have a glucagon inhibiting insulin. There is a figure. You are expected to draw that. And octreotide, lanreotide, they can be asked in short notes. Main use is in acromegaly. Actually, ideally, the treatment is surgical. They are just used as adjuvants in acromegaly and also in carcinoids, AIDS, cancer, chemotherapy, and so on. And then you have dopamine. When you talk about dopamine agonists and antagonists, you can draw this figure. Here you have 4 pathways by which dopamine acts: mesolimbic, mesocortical, nigrostriatal, and tuberoinfundibular pathway. So when you talk about dopamine antagonists, you can say the side effects from here itself. Nigrostriatal pathway block, drug-induced Parkinsonism. Mesolimbic pathway block, you have symptoms like psychosis, like schizophrenia and all. Then tuberoinfundibular pathway, hyperprolactinemia. So this is how you are going to remember the side effects. You're not just going to mug up the side effects. Have some logic, have some rational while reading pharmacology because it is science. There will be a reason behind everything. So you have bromocriptine and carbohydrate. They too are mainly used for pituitary macroadenomas, which produces prolactin. Patients come with galactorrhea, amenorrhea, and infertility. So the main difference between bromocriptine and carbidopa is it is the carbidopa is contraindicated in pregnancy. So you find the female becoming pregnant you have to stop carbidopa. You have to switch over to bromocriptine. Adverse effects I have explained already. That is about bromocriptine and carbidopa. Then they are going to ask you GnRH agonist and antagonist. That is another short notes can be coming in this chapter. So this is how we used to remember. Nafarelin is used intranasally. So GnRH agonist and antagonist main uses hormone-dependent cancers, breast in female and prostate in male. Then to some cases, very rarely in precocious puberty and in endometriosis, uterine leiomyoma. So I have shown you the figure already. If you want, again I will show you. If you are going to draw this figure, this is going to be more than enough for the mechanism of action. But the difference between GnRH agonist and antagonist, when you start GnRH agonist, it is going to produce initial flare-up of symptoms. This is happening especially in prostate cancer. So you have to couple it with 5-alpha reductase inhibitor or an anti-androgen like bicalutamide or flutamide. Whereas when you start GnRH antagonist directly, there is no need because they are going to act as an antagonist directly. So that is the main difference what you have to highlight. So adverse effects I told you already. The symptoms of hormone deficiency. It is in a male, it is going to be gynecomastia, impotence, loss of libido. If it is a female, it is going to be symptoms similar to menopause, like hot flushes, vaginal dryness, osteoporosis, increased susceptibility to fractures, and so on. With this, I think hormones we have covered. Next important chapter will be respiratory system. That drugs main question will be drugs used for bronchial asthma. So that is one essay question. Autocoids, very rarely you get essay questions. Autocoids, sometimes I think aspirin has been asked once as an essay, once or twice. Not very frequent. Yes, rest are all short notes when you talk about autocoids. So when we talk about bronchial asthma, cough, I think it is only asked as a short note, so I'm not discussing about that. When you talk about bronchial asthma, the thing is classification, I think you will write. Coming to beta agonists. So the main point you have to write here is they are selective for beta 2 receptor because earlier when we were using ephedrine, we were using isoprene because they have activity in both beta 1 and beta 2, but at the expense of cardiac stimulation. So we had tachycardia, we had hypertension, and we had arrhythmias at higher doses. But here, what we are doing is we are giving only selective beta 2. So we are not having these side effects. But at higher doses, it can cause. But I mean, therapeutic doses, it is free from all these side effects. So, you know, beta 2, adenyl cyclase, cyclic AMP, then bronchodilation. So, but at higher doses, it can cause tachycardia. Main side effects is tremor, tachycardia, hypokalemia. If you write this when salbutamol is more than enough. Then the main use will be in bronchial asthma and in COPD. Actually, a combination of LABA, that is long-acting beta agonist and inhaled corticosteroids. When you discuss this, they can ask you how it is beneficial. Steroids can increase the beta 2 receptors at the surface. That is, they will promote the upregulation of beta 2 receptors. And they themselves have anti-inflammatory property, which we had discussed already in corticosteroids. So this combination is synergistic. When you discussed about LABA plus ICS, you can tell this point. Then you have long-acting like salmeterol, formoterol. So in this formoterol, you can remember like this formoterol has faster onset of action. When we go about theophylline, main thing what you have to say here is it is a drug which requires therapeutic drug monitoring because it has a very narrow therapeutic index. So theophylline acts by two mechanisms. One is by phosphodiesterase inhibition and other is by adenosine receptor antagonism. So the beneficial effect of bronchodilation is because of phosphodiesterase inhibition. So we have seen in sildenafil vardenafil that increases cyclic GMP, so it produces bronchodilation. So that is the main beneficial effect. But adverse effects are all because of adenosine receptor antagonism. We had a tabular column here. So what adverse effects mainly are you have they are dose dependent. You can see you have dyspepsia, headache, then you have tachycardia, tachypnea, tremors. At higher doses, CNS side effects, delirium, convulsions. So these will be the side effects, arrhythmias. So, and that is one thing you have to highlight. And it is metabolized by CYP1A2. It's not by other drugs like CYP3A4 or CYP2C9 or 2C19. So here the drug interactions, there is a minor change because they are metabolized by CYP1A2. Ciprofloxacin, oral contraceptives, erythromycin. So these can be the drug interactions. Smoking will induce theophylline levels. So smokers doses you have to give at a higher dose. And when coming to drug interactions, one thing I forgot to tell in oral contraceptives is most common thing is when oral contraceptives is enzyme inducers like rifampicin, because tuberculosis patient needing contraception, patient with convulsions needing contraception, you are not supposed to use oral contraceptives because they will increase the metabolism, lead to contraceptive failure, patient will return with pregnancy. Similarly, antibiotics which will interfere with the intrahepatic circulation of oral contraceptives like amoxicillin, ampicillin. You will be thinking we have just given amoxicillin, ampicillin. Patient will return with contraceptive failure. They are the two major drug interactions with oral contraceptives. So that's all about in theophylline. Then you have M3 receptor antagonists. You have ipratropium and tiotropium. Tiotropium difference is tiotropium is binds to M3 receptors irreversibly, so it has a longer duration of action because it is M3 selective. What you're going to highlight it is selective only for the bronchus. So there is no other anticholinergic side effects like dry mouth, sedation, urine retention, constipation, blurring of vision. So all these things are not going to be there. So say for example, you are going to give atropine, you are going to have tachycardia and delirium also at high dose. So it is free from all these side effects because it is M3 selective. And the major use is only in COPD because COPD, the bronchoconstriction is vagally mediated, not in bronchial asthma. It can be used as an adjunct to SABA in bronchial asthma or LABA in bronchial asthma, but not as a primary drug. But this is the primary drug of choice in COPD because COPD bronchoconstriction is vagally mediated. This is one very important point. It is M3 selective and free from side effects of blocking all the receptors M1 to M5, and it is used mainly in COPD. So that is it when you write about this. Then you have leukotriene receptor antagonists, which can also be they are called as steroid sparing agents. When we talk about azathioprine, we refer to as steroid sparing agents. Similarly, they are steroid sparing agents in bronchial asthma, or if you want to reduce the dose of steroids, you can use montelukast or zafirlukast because it also has some anti-inflammatory property. You can see recruitment of eosinophils is decreased, eosinophil count, so inflammation is suppressed, and bronchial hyperreactivity is also suppressed. And these are drugs which can use for prophylaxis and for exercise-induced asthma in children, whichever case it is montelukast and zafirlukast. But their main side effect here, which you have to say talk, is about Church-Strauss syndrome. Can cause increase in eosinophil count themselves, so it can cause Church-Strauss syndrome. When you come to glucocorticoids, the anti-inflammatory effect we had discussed already when we spoke about corticosteroids. So it can also prevent airway remodeling. Inhaled corticosteroids versus systemic corticosteroids. In status asthmaticus, we are using systemic hydrocortisone IV. And in the last step of asthma, in asthma management, it is a stepwise pattern. The last step you are adding prednisone. Otherwise, it is only inhaled corticosteroids. I've already told you how it is synergistic because it will upregulate the beta 2 receptors. So the combination of beta LABA plus ICS is synergistic. But when you come to side effects of corticosteroids, we have discussed in systemic corticosteroids. Oral corticosteroids are going to have a different side effect profile. Especially you have hoarseness of voice, dysphonia, sore throat, and candidiasis because it is an immunosuppressant. This candidiasis can be prevented if you ask the patient to rinse them out after using the metadose inhaler, or it can be stopped. When it occurs, you can treat it with nystatin or cotrimazole. These are things they are going to ask. Budesonide, fluticasone, cyclosonide. These steroids will have very high first pass metabolism because even though they are taken into the systemic circulation, side effect should be minimal. So mostly these are steroids which will have very high first pass metabolism. Cyclosonide, one important property is it is metabolized by the esterases to release the active moiety. So it is a prodrug. Omalizumab, I think you will write it is a monoclonal antibody against IgE. So it prevents the monoclonal IgE binding to the mast cells and release of inhibitors. Release of asthma mediators. So because of that, there is no bronchoconstriction. Here they can ask you whether antihistamines can be useful in bronchial asthma. The answer is they are only partially effective because asthma is mediated via various other mediators like leukotrienes, and you have a lot of other bronchoconstrictors playing a role. So there is no antihistamines are very minimal load in bronchial asthma, but they are used in other allergic conditions. So you can say that. So this is how it is, starting with SABA, then you add inhaled corticosteroids, then you add LABA plus ICS, or sometimes you can add a Montelukast, Zafilukast here. Then finally you go for oral corticosteroid prednisolone. So this is the stepwise pattern, the management of asthma. So with this, I think RS is RS. The only question they are going to ask is bronchial asthma, cough. I think you will manage. You can write cough. It's not going to be asked as an essay question. So we'll move to the final autocoids. In autocoids, very rarely they can ask aspirin as an essay question. Apart from that, they are all drugs are all short notes only mostly. So when first is histamine. When talk about histamine is not going to come in any question. Antihistamines will come as an essay question. Short notes, especially second generation ones can come as a short note. So when you talk about antihistamines, you have first generation and second generation. So when you talk about first generation, they have additional anticholinergic property as well. So then they are highly sedating. So side effects are sedation, and because of the anticholinergic property, you can have, again I'm repeating the anticholinergic side effects: dry mouth, urinary retention, constipation, blurring of vision. So any anticholinergic is contraindicated in two places: benign prostatic hypertrophy and acute angle closure glaucoma. But these anticholinergic property of these drugs can be beneficial in two places. One is used in motion sickness, and other is used in drug-induced Parkinsonism. So that can be translated to a beneficial effect as well. When you talk about second generation antihistamines, they are free from these side effects, sedation and anticholinergic property, and they also have some additional anti-inflammatory property. So they are they have more use in conditions like allergic conditions like rhinitis, conjunctivitis, and so on. So we have discussed this already. I've told you about this anticholinergic action. Here they can ask you about a motion sickness treatment, and second generation antihistamines. Anything can be asked in short notes. Any drug, because they are very important. Now, astinosine terfenadine produced prolongation of QT interval, but it is banned now. But drugs prolonging QT interval can come as a short note. What tortoise torsitis dispointus and what are drugs causing torsitis dispointus can come as a short note or 2 marks or MCQ or whichever. They cause prolongation of the myocardial action potential by blocking the delayed rectifier potassium channel. So the repolarization will not take place because of that, especially when you combine with enzyme inhibitors like erythromycin, clarithromycin, and ketoconazole. So here you can see the additional properties of these second generation antihistamines like blocking of the addition molecules, so recruitment of eosinophils and inhibition of release of leukotrienes and so on. So they have the additional anti-inflammatory property. So they are used in rhinitis, sinusitis. I think you will write this. Then motion sickness can be asked as a short notes. So that also I think we will skip. Then we will move to migraine. Here straightly we are moving on to treatment of migraine, because serotonin and the receptors they are not going to ask you. Migraine, what you have to start with the theory of migraine. What are the two theories for migraine? Vasodilator theory and neurogenic theory. So when you talk about vasodilator theory, it is because of dilation of cranial blood vessels. Neurogenic theory, they are saying it is because of the nerve endings get excited and release certain neurotransmitters, especially calcitonin gene-related peptides. So these are two theories. You have ergot alkaloids, triptans for the treatment of migraine. And when migraine itself can produce emesis, ergot alkaloids, they have highly emetic potential. So it is always advisable to start them with antiemetics, metoclopramide, domperidone. Coming to ergot alkaloids versus triptans, the major difference is ergot alkaloids are 5-HT2 receptors agonist as well as partial agonist as well as antagonist, and it also has alpha partial agonist as well as antagonist. But main receptor involved in the vasodilation of your cranial, especially meningeal blood vessels, is 5-HT 1B 1D subtype, and triptans are very specific for that 1B 1D subtypes. So they will cause vasoconstriction. Whereas here they are not specific for the 5-HT1B 1B subtype, and because of additional alpha blocking property, they have problems and partial agonistic activity with alpha also. They can cause vasoconstriction of other places. So they can cause coronary vasospasm, they can cause myocardial infarction, they can cause hypertension. So these will be the problems, and they are strongly emetic. They have strong emetic potential. So you have to give them with MSS, anti-emetic drugs. So, and they're absolutely contraindicated in 3 places: coronary artery disease, stroke, and in people with hypertension. Whereas triptans, don't have this alpha blocking property. They are very selective for 5-HT1B, 1D. So that is, you can compare and contrast. Other use of ergot alkaloids we have seen already: induction and augmentation of labor, as well as in prevention of postpartum hemorrhage. So when you come to triptans, specifically sumatriptan is one thing which you can give parentally. Rizatriptan and naratriptan, zolmitriptan, they are long-acting triptans. Migraine prophylaxis, they can ask you. You can just write about beta blockers, tricyclic antidepressant, and calcium channel blockers, especially flunarizine, which blocks the calcium channels in the brain. So decreases the release of neurotransmitters. So according to the neurogenic theory. Then this is a recently developed drug. They can ask you in MCQ, erenumab, which is a CGRP receptor, a monoclonal antibody against CGRP receptor. Because when we spoke about neurogenic theory, I told you it is because of release of neurotransmitters like CGRP. This can come as a MCQ. So apart from this, there is not going to be anything. Then prostaglandins, we are going to straight away move on to uses of prostaglandins, which is the thing which we are going to ask you. Sometimes they have asked you obstetric uses of prostaglandins. Sometimes they have asked you general uses of prostaglandins. How I used to remember is starting from a female getting pregnant till delivery. So first, when a female gets pregnant, she wants to avoid pregnancy. So first step is mid-trimester abortion. So it can be given up to 7 weeks, along with, we have read already, mifeprostone 600 and misoprostol 400 microgram. A main problem is when you use prostaglandin is they can also cause bronchoconstriction. So it is contraindicated in bronchial asthma patient. Diarrhea can be a side effect. And uterine spasm, that is why we are using it for abortion. So these are main important side effects when you use prostaglandins for abortion. Okay, then fine, she is not able to abort. We move on to the conception. Now she is in labor, induction and augmentation of labor, ripening and softening of cervix, cervical dilatation. Now, after all this has happened, your uterine contractions are like not enough. So you can use this for augmentation of labor, but it's not as effective as oxytocin. Now, finally, she has delivered the baby. Now, I want to arrest her postpartum hemorrhage. So you can give carboprost as an IM injection. Postpartum hemorrhage, it is treated with 3 drugs. Usually, what we do is practically we give oxytocin 5 units IV via normal saline drip. Then we will give methyl ergometrin IM. If it is not controlled, we go with carboprost IM. So this is how we give. These are the obstetric uses. Sometimes obstetric uses of prostaglandins alone can be asked as a short note, or sometimes they can ask uses of prostaglandins also. Glaucoma, the drugs which are effective in glaucoma are in 2 types. Drugs which will decrease the secretion, which will increase the outflow. In outflow, you have trabecular as well as uvoscleral. Uvoscleral outflow is increased by prostaglandins, latanoprost, divertoprost, and pravoprost. And to maintain the latency of ductus arteriosus, especially in patients with TGA, transversion of great vessels, the circulation is because of this patent ductus. So until the corrective surgery is done, you need to maintain PGA. You can give alprostadil. Pulmonary hypertension, peripheral vascular disease, importance we have already seen alprostadil. So side effects I have told you already 3 things: bronchoconstriction, bronchial asthma, diarrhea, uterine cramps. So these are the main side effects of prostaglandins. So that's it in prostaglandins. Then the final chapter for today is NSA. NSAIDs actually, they can ask any drug in this as a short note. Main thing what you have to do is you have to draw this arachidonic acid pathway, phospholipase A to then cyclooxygenase, then lipoxygenase pathway. If you draw that figure, that is enough for your mechanism of action. And I think the figure was given in earlier Tripathi edition, but newer edition it was missing. So when you have beneficial actions are because of prostaglandin synthesis inhibition. You have when you talk about aspirin, I will go like this. When low dose aspirin, we have lead already 75 to 150 microgram. It is used as an antiplatelet because it inhibits COX-2. Because of that, it inhibits thromboxane A2 synthesis. As you increase the dose, it has antipyretic, analgesic, and anti-inflammatory effect. And finally, overdose, it is you have aspirin poison. And these are the beneficial effects. And toxicities will be mainly because of prostaglandin inhibition. You have gastric ulcer, bleeding, and because of interference with tubuloglomerular feedback. Prostaglandin TGI2 is one place where tubuloglomerular feedback is maintained. So because of that, that is why when we take NSAIDs, they say it can precipitate acute renal failure. So, and asthma anaphylaxis, we have an entity called as aspirin-induced asthma itself and delayed prolongation of labor. So, if you want to close patent ductus arteriosus, you can give indomethacin. But as when there are certain places where you need PDA to be open, especially in transpiration of great vessels. Then, how does it cause gastric ulcer? They can ask you. One is because of inhibition of prostaglandin synthesis, because of mucosal bicarbonate secretion is inhibited. Other is a theory called ion trapping theory. They can ask this in Viva. Ion trapping is that aspirin is acetyl salicylic acid, isn't it? So what happens is when it enters in acid, when you take an acid, they are unionized in acidic medium. Inside your stomach, it is acidic pH 1 to 1.5 or something. So this acetyl salicylic acid is unionized. So once it enters the gastric mucosa, the inside any cell pH is neutral. So it dissociates into salicylic acid and acetate moiety. But it is not able to re-diffuse back to the stomach because it has dissociated and become ionized. Ionized ducts cannot cross the lipid barrier. That is why it is trapped inside the mucosa. That is what is called as ion trapping. So they produce ulcer by two effects. One is because of its COX inhibition. Other is because of ion trapping theory. Renal we have discussed already. Aspirin can be asked as a essay question. Very rarely they have asked. And coming to aspirin, metabolic, this they can ask you. What are the disturbances in aspirin? First, what happens is because of then there is first metabolic acidosis because then you have respiratory alkalosis as a compensation. Then finally it goes for respiratory acidosis. This is very very important. And coming to aspirin poisoning and paracetamol poisoning, I'll take this together. See, whenever you have any poisoning, you have to write it in these three subheadings: general management, supportive management, and specific management. In general, it is always going to be stabilizing the patient, A, B, C, airway, breathing, circulation. Then you are going to talk about supportive, specific correction of fluid electrolyte, correction of acid-base imbalance, maintaining of blood pressure. Coming to specific, if you have a specific antidote, you mention the antidote. If there is no specific antidote, please write there is no specific antidote. Then you have, forgot to mention, in general, you have gastric lavage, activated charcoal, all these things come under general management. Then finally, the poison has entered your systemic circulation, hemodialysis. So this is how you have to write a case of poisoning. Because for 5 marks, if you are aiming to get 4.5, if you write the name of the antidote alone is not enough. Maybe in MCQs it is enough. Like, what is the antidote for benzodiazepine overdose, flumazenil? That is more than enough. But when you talk about a short note, unless you are writing it in these subheadings, you might be thinking that I have written the antidote, I'll get full marks. That is not the case. Okay. So acute salicylate poisoning, we have seen about the electrolyte changes already. Apart from that, there can be vomiting, dehydration, convulsions, and death. Here, aspirin poisoning, there is no specific antidote. So here it is only supportive measures. And since this is acid, acetyl salicylic acid, you can do forced alkaline diuresis. If it is for alkaline drug, you can do forced acidic diuresis. Since you have bleeding, you can give vitamin K. Okay. So, but when you come to paracetamol poisoning, what is the difference? Is there is an antidote. Paracetamol poisoning primarily manifests as hepatotoxicity, acute pulmonary hepatitis, jaundice, and so on. But there is a specific antidote called N-acetylcysteine there. But whereas here you don't have a specific antidote. And toxic metabolite of paracetamol is NABPQ, N-acetyl para-amino benzoquinone. It is metabolized, paracetamol is metabolized by CYP2E1. This is another important point. And alcohol induces CYP2E1. So the dosage of paracetamol which produces poisoning is lesser in an alcoholic patient when compared with a non-alcoholic patient. So these are the important things where you have to discuss when you talk about paracetamol poison. Use, I think you will write analgesic, antibiotic, anti-inflammatory, rheumatoid arthritis, osteoarthritis, all these things you will write. Low dose aspirin, it will be discussed in detail by whoever is taking CVS. But I told you the mechanism of action already. Adverse effects we have discussed already. Peptic ulcer, then they can cause myocardial infarction, liver transaminases, bleeding, thrombocytopenia, can exacerbate asthma. I think they have all been discussed already. So whichever NSAID is asked, you can write all these things because they are very common. Drug interactions, and these are drugs which have very high plasma protein binding. So sulfonylureas, warfarin, methotrexate, these are salient drugs where you can highlight. Digoxin also. Paracetamol poisoning, I think we have discussed already. Then they will come to selective COX-2 inhibitors. They can ask you what is the advantages of selective COX-2 inhibitors, because select COX-2 is one enzyme which is um, expressed only at the site of inflammation, whereas COX-1 is constitutional. So the housekeeping functions of COX-1 will not be lost, like in gastric mucosal production, right, in kidney. That will not be lost. Whereas only the anti-inflammatory property of NSAIDs will be retained. But that is how these drugs were developed. But later what they're, see, you can see, juxtagloma COX-2 is constitutive. So renal will not be damaged. Ulcer will not be occurring when you give COX-2 inhibitors. But later, they found these COX-2 inhibitors can precipitate myocardial infarction and thrombosis because the protective effect of PGI2 as an antiplatelet aggregatory is lost when you give COX-2 inhibitors. So its use is still like nobody sure about it. So paracetamol, I've told you already, NABPQI, hepatic necrosis, jaundice, and chronic alcoholics. I told you, I've discussed about this already. Final stage of paracetamol poisoning we can go is liver transplantation. I'm not going to tell you about criteria. There is a criteria called King's criteria. Based on that, they will decide whether the patient should go for transplantation of liver. So that's all I think in NSAIDs. Okay, then finally rheumatoid and gout. Um, Rheumatoid arthritis, main thing here is we'll talk about each drug. Steroids, we are not going to discuss. When you talk about methotrexate, main thing you have to highlight here is it is given in low dose, thrice weekly. Because it is given chronically in low doses, pulmonary hepatitis risk is more in patients with rheumatoid arthritis. So other side effects of methotrexate you will read when you talk about anti-cancer agents. Inhibit dihydrofolate reductase, you know. So there is no tetrahydrofolate. Because of there is no tetrahydrofolate, there is no methyl tetrahydrofolate. Since there is no methyl tetrahydrofolate, there is no carrier for methyl group, then uracil cannot be converted to thymine. That is how it inhibits DNA synthesis, and it also has some anti-inflammatory property. Methotrexate is one drug which is toxic to the entire system. It is hepatotoxic, it is renotoxic, it competes for plasma protein binding, it is teratogenic, you cannot give in pregnancy, and it also has some GI ulcer property. So it is one drug which is highly toxic. Bone marrow suppression can cause anemia, leukopenia, and thrombocytopenia. So it is very highly toxic drug. And azathioprine, one important point what I would like to tell here is it is metabolized by the enzyme TPMT, thiopyrin methyltransferase. So people with polymorphisms of TPMT, they are people who are increased susceptibility to develop bone marrow depression, and this drug interaction is very, very important. Azathioprine with allopurinol, because azathioprine is also metabolized by xanthine oxidase. Allopurinol inhibits xanthine oxidase, and because of that, the bone marrow suppression of azathioprine will be more when you give along with allopurinol. Sulfasalazine is somewhat safe. It is main thing is hypersensitivity because of sulfa can cause agranulocytosis. That is one main thing. Hepatitis also. Hydroxychloroquine, main thing is it is highly safer drug, and but you have to screen for retina because it can cause retinal damage in higher doses. Then TNF alpha analogs infliximab, adalimumab, and infliximab, adalimumab, and anakinra. When you talk about these drugs, they are all given either subcutaneously or intravenously. Since they are immunosuppressants, main side effect will be increase in opportunistic infections, especially flaring up of tuberculosis. So you have to take a chest X-ray before starting these drugs. Sometimes increase in risk of secondary malignancies as well. So that's all. Corticosteroids we have discussed already. Gout, I think you will write. Gout main thing is one NSAID you cannot NSAIDs they are given, but you cannot use aspirin because gout aspirin has a tendency to compete with uric acid at higher doses, so you cannot use that. Then so in that cases, whenever NSAIDs are contraindicated like peptic ulcer, you can go for or in renal failure you can go for colchicine, and colchicine interferes with the migration and of neutrophils, and they can also phagocytose the uric acid crystals. And but one main side effect of colchicine is diarrhea. That is very, very important. You have to write. Then uricose uric drugs which will excrete uric acid, and they are probenecid and sulfenpyrrosone. They inhibit this enzyme organic anion transfer. So other drugs which are competing with it, penicillin and other drugs like methotrexate also sometimes they can interfere with this organic anion transfer. So you can see in the drug interaction, penicillin, cephalosporins, methotrexate. So there is competition for excretion. And allopurinol we have discussed already. It is inhibiting the enzyme xanthine oxidase. Allopurinol is used for chronic gout. You cannot use uric acid synthesis inhibitor in acute gout. In chronic gout, only you can use. Even if you want to start allopurinol, you have to wait for 4 to 6 weeks with colchicine or other uricose uric drugs. Only then you can start allopurinol. That is very, very important. So it is, you can see it is a prodrug. It is converted to alloxanthine, which will inhibit the enzyme xanthine oxidase, which converts, which is the responsible for the generation of uric acid. So this we have discussed already. Important drug interaction with azathioprine. Dose should be reduced to 1/3. Otherwise, azathioprine induced bone marrow suppression will be happening here. Apart from that, allopurinol has hypersensitivity. There is increased hypersensitivity reactions, Stephen-Johnson syndromes, and so on. It is contraindicated in pregnancy. It is teratogenic. So you have a new drug called febuxostat, which is free from the side effects of allopurinol. Then you have pegloticase. It is an enzyme. It is recombinant uricase, which converts this uric acid to soluble allantoin so that they can be excreted by the in the urine. So I think with this we have covered RS autocoils. I think for GIT, uh, can I take some 10 more minutes extra if it's okay for everyone? Because GIT, the only topic which is important is peptic ulcer. Rest antiemetics, emetics, prokinetics will be coming in short notes only. Okay, since nobody is responding, I will take peptic ulcer as well and we'll finish it off. Just another 5 to 10 minutes. Constipation and diarrhea, ORS, composition of ORS, what is low osmolar ORS, what are the advantages of low osmolar ORS? These are things they are going to ask you. When we talk about peptic ulcer, this is the figure which I expect if I am correcting a paper. Because your gastric secretion is happening in 3 phases. You must have, 4 phases you must have read in your physiology: cephalic, gastric, intestinal, and interdigestive. So cephalic phase is vagally mediated. Everybody knows that. So your anticholinergics M1, pyranzapine, telanzapine is acting in the cephalic phase. Gastric phase you have mediators like histamine getting released, acting by H2 receptors. So finally they are acting to this pump proton pump H plus K plus ATPase releasing HCl. So his H2 antagonist, cimetidine, nanitidine, famotidine. And then you have proton pump inhibitors. Why these are the most efficacious drugs is because they act in the final common pathway, whether it is stimulated by histamine, whether it is stimulated by gastrin, whether it is stimulated by any other pathway, it is going to be terminating in this stimulation of H plus K plus ATP. So you have proton pump inhibitors. Then gastric phase, intestinal phase where you have gastrin acting via G cells and stimulating acid release. Then you have interdigestive phase. So when you talk about anti-ulcer drugs, that figure is a mandatory one. H2 blockers, they are not going to ask you because they are not efficacious like proton pump inhibitors these days, but they can also decrease the volume of the gastric juice and basal acid secretion, especially nocturnal acid secretion, they can reduce. So that way they are a little bit advantageous as H2 blockers. But still, I told you acid can be released by other stimuli, by acetylcholine, by gastrin, by histamine. On these blocks only acid release via histamine, so they are not that very efficacious. When you talk about cimetidine, it has a lot of side effects. It is an enzyme inhibitor, so a lot of drug interaction and side effects because it inhibits the androgen receptors binding. So you have gynecomastia, loss of libido, and impotence. Whereas anitidine, famotidine, roxetidine, they don't have all that side effects. Only cimetidines have this anti-androgenic effect. And anitidine is more potent. So all these things you will write. Uses are in peptic ulcer and bleeding from severe peptic ulcer, non-ulcer dyspepsia, and in some cases of gastroesophageal reflux. Same uses will come in proton pump inhibitors also. Prophylaxis of aspiration pneumonia. Proton pump inhibitors, they are most effective, because they will block the final common pathway of all the drugs. So they block the H plus K plus ATPase enzyme. Then you have omeprazole. When you talk about omeprazole, it has a lot of side effects because it inhibits CYP2C19. One important thing you can highlight is use with clopidogrel. So it will lead on to clopidogrel failure. Patient will present to you with thrombosis. Whereas it doesn't. Panta and rabiprazole don't have the side effect. Panta is the longest acting, most efficacious. R for R. Rabiprazole is rapidly acting. So you need faster acid suppression. You can give rabiprazole. So uses are the same. Peptic ulcer, you will use it for 4 to 6 weeks. That is very, very important. Only then you can stop this drug. And still they are the drug of choice for drug-induced gastric ulcer. Usually we say NSAID-induced gastric ulcer will give prostaglandin, misoprostol, alprostadil, but H2, proton pump inhibitors are the most efficacious drugs. Bleeding peptic ulcers, stress ulcers, gastroesophageal reflux, Zollinger-Ellison syndrome, gastrin-producing tumors, where you have ulcers in uh, uncommon locations, multiple ulcers. Here you use them in higher doses. Antacids these days they're not asking because those drugs have become obsolete. One thing you can say is magnesium produces constipation. Aluminum produces constipation, magnesium produces diarrhea. So they neutralize the acid. You have acid neutralizing equivalents and all that. So antacids, sucralfate can come as a short note. Sucralfate and colloid bismuth substrate. So because in the acidic phase, these drugs get polymerized and they cover the ulcer base. So that is how, and H. pylori will not be able to bind further. Sometimes even the bound H. pylori can be dislodged. So that is sucralfate, and sucralfate is taken before each meal, 3 major meals. So that you can say constipation, bloating, and all that will be a side effect. One thing if I am sitting as a Viva examiner, I will definitely ask what are the regimens for H. pylori eradication, because it is very, very important. Here the duration of treatment is 2 weeks. You have triple drug and quadruple drug. Both the one integral component is proton pump inhibitor. In triple drug regimen, you have amoxicillin, clarithromycin, and or metronidazole, because in India you have metronidazole resistance because you use it for amoebiasis, giardiasis, and so on. So in that case, it is amoxicillin, clarithromycin, and one of the proton pump inhibitors. In quadruple drug regimen, it is OBTM, omeprazole, colloid bismuth substrate, tetracyclines, and metronidazole or clarithromycin, and duration of treatment is 2 weeks. This is very H. pylori eradication regimen. It is a mandatory thing you should know. So that is in peptic ulcer. That's for constipation and diarrhea. Laxatives they can ask in short notes, but these days these topics are becoming more and more obsolete. So I think we have covered everything. So in prokinetic drugs, anti-emetic drugs, they are either 5-HT agonist or antagonist. 5-HT3 antagonist, prokinetic drugs are 5-HT4 agonist, because serotonin is one which is released from your ECL, enterochromaffin-like cells, stimulates the K1 receptor, digosome. Ondansetron and granisetron, mainly they are used for two places: post-operative nausea and vomiting and post-cancer chemotherapy-induced nausea and vomiting. Highlight that is more than enough. Metoclopramide and domperidone, they are D2 receptor antagonists. Metoclopramide can cross the blood-brain barrier, so it can cause drug-induced Parkinsonism, whereas domperidone, the incidence of drug-induced Parkinsonism is comparatively lesser when compared to metoclopramide. And you have 5-HT4 agonists like cisapride, mosapride, which are prokinetic agents which will stimulate motility. Some of them can prolong the QTC interval. So especially cisapride is banned these days because of the drugs to cause torticollis dispointus. Please make a note as you read which drugs cause torticollis dispointus. And they can be asked in MCQs or short notes or wherever possible. Definitely one question will come for this. So I think with this is what I was able to prepare and able to deliver within the short time which you all had. If there are any doubts, you can post them in your WhatsApp group. And one more thing before I finish, I would like to tell you is passing your pharmacology exam is important, which is actually important is trying to get into a postgraduate course or trying if you are aiming for USMLA or something. That is also equally important. You should have done this, but okay, if you are not done this, also it's no problem. Whichever chapter if you are reading, please work out the MCQs. If you are aiming for a NEET PG or something, I don't know whether NEET or next you have lot of confusion, but whatever it is, syllabus is going to be the same. Please buy some MCQ book, like you have MCQs in Tripathi, you have Sparshgupta MCQs. Please work out the MCQs as and when you complete the chapter. If you're aiming for USMLE or something like that, you have a book called Katsang Board Review. Please work out the MCQs as and when you finish a chapter. And or if you're not done it so far, no problem. After our exam, before you start reading your pre-final year textbooks, because you have freshly completed your second year, please work out the MCQs. Because passing your exam may be as important now, but when you go for any competitive exam, it is going to be only MCQs and MCQs. So when you are not thorough with the MCQs, not going to be useful in the long run. So please work out your MCQs. I would also like to tell an example. I had a student, I was working in SRM, and he used to do this. Whichever internal is over, he used to work out the MCQs immediately then and there. And during COVID time, when there was a lockdown, he used to participate in all the quizzes of pharmacology, whichever place it was conducted online. He got MS General Surgery in first attempt in Coimbatore Medical College. He is from Coimbatore. He is studying in Coimbatore Medical College now. That is because he has worked himself from second year. It not happen in a single day. So that's one personal advice I would like to tell you. Thank you everyone for listening very patiently. If you have any doubts, you can post them in the WhatsApp group. And thank you NMO for giving me this opportunity to share whatever little I know. Thank you all.
Thank you, ma'am. We will end the meeting with the NMO Shanti Mantra.
Shanti mantra. Sarve bhavantu sukhinah. Sarve santu niramayah. Sarve bhadrani pashyantu. Ma kaschit dukkhavaag bhavet. Om Shanti Shanti Shanti. Namaste.
Thank you, ma'am.
Thank you.